founder of Life 365, and welcome to Season 3, Episode 4 of The New Normal. Today's episode, we will be discussing technology and programs used to connect our veterans to care. I want to take a minute to thank our panelists for joining us today and sharing their valuable time in addition In addition to being business leaders and healthcare industry experts, all of our panelists today are veterans having served in our nation's armed forces. You have used your life in a way that blesses so many, and you continue to serve and help others. Thank you. As for the structure of this webinar, attendees will be on mute, and we have reserved time at the end for questions. Please place your questions within the chat. You can review the recording of today's webinar on www.newnormal.buzz. So just for an introduction, poor access to care can equate to poor health, and rural patients often have higher rates of chronic diseases like diabetes, heart failure, and COPD. Oftentimes, individuals must choose between waiting months to see a provider that is hours away or skip care altogether. Today, we are going to discuss how telehealth expands access to care and how technologies are keeping our veterans safe, connected, and healthy. Dr. Wise from Valor Healthcare will also share how his organization is excelling at providing care for our veterans. I personally have been in digital health for the past 15 years and have had the honor to testify to the House Subcommittee on Veterans Affairs concerning healthcare in rural and highly rural areas. So the topic is very near and dear to my heart. Now I want to introduce our distinguished panelists. Rob Ray, retired U.S. Navy Rear Admiral, is CEO of BlueStar SeniorTech, a provider of technology services to hospital, FQHCs, physician groups, and individuals. A mechanical engineer from Naval Academy, Rob spent 7 years of active duty as a nuclear engineer on surface ships, carriers, and submarines. Transferring to the reserve, he enjoyed a varied 20-year career in business, manufacturing, hospitality, technology, consulting, and construction. After being mobilized to Iraq, he was promoted to admiral and placed back on active duty for 6 years. He holds a master's degree from Georgetown University's Business School, is a licensed professional engineer, holds a patent, has written 2 books on leadership, and is a frequent speaker on leadership and business. Joel Bartholomew. As a founder and CEO of GlobalMed, Joel has a mission to provide the best technology for patients and providers to realize a world without disparity of care. With more than 3 decades of expertise and iconic leadership in the technology industry, Joel has spent his storied career focused on the development and advancement of virtual care health systems. Under Joel's leadership, GlobalMed powers the world's largest, most advanced virtual care programs and is a single telehealth technology provider to the Department of Veterans Affairs, DoD, federal and state prison systems, payer and provider groups in the US and internationally, governments and militaries around the globe. GlobalMed has provided 50 million consults delivered in nearly 100 countries. He is also an active board member for various organizations and gives back to the community through contributions and generous commitments to more than 15 programs. Joel attended St. Cloud State University and received an honorable discharge as a non-commissioned officer from the United States Marine Corps Reserves in 1987. Dr. Scott Wise, a U.S. Army veteran, is President and Chief Executive Officer for Valor Healthcare. A graduate of the University of Texas Southwestern Medical School at Dallas, he also holds an MBA with a focus in healthcare administration from the Eisenberg School of Management at UMass Amherst. After leaving the Army in 1998, Dr. Wise was in private medical practice for 10 years before joining Valor in 2007. He also held successive roles at Valor, beginning at Clinic Medical Director before being named the company's Chief Medical Officer, Chief of Staff, Chief Operating Officer, and now President CEO since 2014. So we definitely have a distinguished group of panelists today. So thank you for joining us. So just a little context to what we're going to do to provide context going forward. I'm going to ask the panelists to briefly share some information regarding their current roles and the organization. So let's start with Dr. Wise. Can you tell us about Valor Healthcare and the services you provide?
Absolutely. Thanks, Ken. Good afternoon, everyone. Valor Healthcare is a national federal government healthcare services company. Our largest customer today is the U.S. Department of Veterans Affairs, for whom we design, build, staff, and operate community-based outpatient clinics. Seeing over 500,000 patients per year in over 50 locations across the country, Valor is actually second only to the VA itself in the direct delivery of primary care services to America's veterans. In addition to primary care, we also deliver preventive medicine, behavioral and mental health care, including diagnoses like depression, anxiety, post-traumatic stress disorder, and so on, and long-term care of chronic disease like heart disease, cardiovascular disease, diabetes, lung disease, and so on. Much of our care is, of course, accomplished face-to-face, but we also do a tremendous amount of telemedicine care in our clinics. For example, telemental health, teledermatology, and teleretinal screening for diabetic patients.
That's awesome. So I want to go to Joel really quickly. Let's talk about GlobalMed. GlobalMed is the leading provider, of telemedicine and virtual care products. Can you provide some background on GlobalMed and the products you provide?
Sure, thank you. First of all, I just want to say I'm honored to be here, Kent, and with Admiral Ray and Dr. Weiss, an honor to be in this call with you. So GlobalMed, 20 years in the telemedicine, telehealth industry, a little over. We have focused, our primary focus right at the get-go was high acute care. And so that difficult type telemedicine visit where you have all sorts of devices attached and getting data from the patient at the same time as you have a video call going on. But let's say allowing a clinician remotely to zoom in a camera that a med tech or corpsman is using an ultrasound trying to see how full the bladder is. So that's a very difficult thing to do, but we were able to do that and continue to do that with about somewhere around 55 different modalities of care. So as you mentioned, the VA, so we're in about 1,700 community-based outpatient centers with the VA, and everything from auscultations to audiology and all the different ologies in between, providing that care, actually providing the technology for the care, and then writing it off to either Vista Imaging or Cerner repositories. So really emergency department on the acute side, hospitals, inpatient, outpatient care, long-term care facilities, and then just even in urgent cares and physician offices. But then we have a whole nother side of our business, which is wellness and behavioral health. And so we provide wellness applications to 7.5 million active duty service members and their families through our wellness apps called Love Every Day. So we touch the patient in a lot of different parts of the continuum of care. And so it is a daunting job at times to do so many things, but it's sometimes easier to have one platform to go across between the different needs for both pre and post and the acute care side.
Awesome. I'm going to come back to you and talk about engaging the patient or the vets. But Rob, you're the CEO of BlueStar SeniorTech. Tell us BlueStar's actually mission.
Well, first, thanks, Kent. And my hat is off to Scott and Joel for the things that you guys do. Our mission as a nuclear engineer retiring from the Navy in my 50s was to take care of seniors in their home. And the senior population was growing rapidly, the fastest growing demographic in the country. All our friends and my parents and my wife's parents and all our friends' parents were all in their 70s and 80s and 90s. So a huge demographic issue, and then huge tech opportunities. the ubiquity of Wi-Fi, the smartness of smartphones, IoT, the Internet of Things, wearables. And so we put those together to try to say, how can we use technologies to take care of older moms and dads in their homes? And I used to call it poor man's telehealth because we weren't clinical. We didn't call it healthcare. We just called it family taking care of family. And so we focus on keeping folks safe, healthy, and connected in their homes. Fast forward 5 years, COVID, telehealth, new rules from CMS, and we're focusing on something that we used to sell to families. We're focusing on a very narrow area now of providing remote patient monitoring and chronic care management in the homes. And we're finding now that we're being called a healthcare company, and we now have doctors and nurses on staff, and we're trying to deliver that last mile of telehealth into the home, again, usually for seniors, trying to keep them safe and healthy and connected. So in that regard, our mission hasn't changed. There's just the modality of how we perform that mission has changed.
Awesome. So Dr. Wise, I'm gonna go back to you really quickly. I remember, it's probably about 10 years ago now, where Phoenix was, VA was kind of getting dinged because of access to care by veterans. There were long waits for vets to be able to get access to see their doctor. How does, how does Valor help with the VA to try to increase access to care to veterans, especially in rural locations?
Well, Ken, I think the first thing is there were certainly, you're talking kind of in the 2015 to 18 time period where Veterans Affairs did get a fair amount of bad press. And Phoenix kind of turned into the epicenter of that, but there were scheduling challenges across the country. I think certainly a part of that is deserved, but I do think I think VA should be recognized because it's very, very true that they have been on the cutting edge of technology in healthcare for decades, and I don't think it's honestly recognized. They were one of the forerunners with the electronic health record. In fact, their electronic medical record, CPRS, really has been the genesis in many respects to the electronic health records that you see kind of off the shelf today. And in fact, they even donated it as open source software probably 15 or so or more years ago. That was certainly one of their cutting edge contributions. The other, I think, really was telemedicine. I've been at Valor since 2007, and we've been doing telemedicine certainly since then, and they were doing it prior. So I think the access, our company focuses on three things when we think about how we partner with VA medical centers around the country and how we take care of veterans. And the 3 points of emphasis are obviously, number one, clinical quality. Not only are we a healthcare company, but we are one run by a physician. So if we can't deliver superior clinical outcomes to our VA partners and to our veteran patients, then we're not adding value. So we certainly hang our hat on that. The second thing that we focus on is the patient experience. We collect a lot of data directly from VA systems and track and trend that data as well relative to how patients are being treated and receiving care in our locations. And then kind of full circle back to the origin of your question is access. How quickly can veterans get an appointment? And I would also say that the VA is doing a very nice job today in that respect as well, because they are limiting, making it a requirement, not only for their own healthcare facilities, but any contract facilities as well, that patients brand new patients new to VA healthcare have to be seen within 20 days of enrolling. So I think they're really rebounding very nicely in terms of being able to deliver healthcare appointments to veterans when they need it and where they need it.
Just really quickly, I mean, when I did testify in front of the subcommittee, it was quite a while ago. I think it was in 2014 timeframe, about the same time that was going on probably with the Phoenix issue that was out there. The big concern was access to care in rural locations. They were finding that if people didn't have access to a doctor, right, and maybe they're 3 hours away from their doctor from that perspective, they would a lot of times exacerbate their disease state, right? And it would get worse. The next time they're going to see them is in an emergency room. So, from your perspective with Valor, how do you treat the rural patients that are out there that you're working with? Is there any special programs you put in place to deal with people that have maybe limited access to immediate care?
Yeah, I think obviously the one of the key points of discussion today is how we leverage technology to bring care to the rural veteran community. As I said, we've been doing telemedicine with our VA patients for a long time. I think the technologies that Joel and Rob and their teams have brought to the fore are really going to move that initiative forward in leaps and bounds. And well done to you guys and your teams. What's really exciting, I think, for me both today and as we look into the future, Joel mentioned a lot of the telemedicine capabilities that include devices that can be utilized by a physician remotely, as long as there is a tech in the room, to include things like a stethoscope and sonography and otoscopes and ophthalmoscopes. And as long as you have patients that are appropriate for those technologies in terms of acuity, and you have a capable technician in the room, which is very easy to accomplish, you can absolutely care for, track, monitor, and treat many chronic diseases remotely. I would never say as a physician that we're going to get to the point where we will not have to lay hands on a patient. I think that is always going to be part and parcel of how we take care of folks. But as we move into a technology-based present and or future, we are absolutely going to be able to do more and more things with patients in their home or wherever they are residing, hospital, nursing home, long-term care facility, or what have you, and being able to leverage technology, number one, to make sure we are continuing to deliver the quality of care that is required by our national standards, but be able to do that with the patient's convenience, the patient's and their family members' convenience, I think is really exciting.
Awesome. So Joel, really quickly, you've been around the industry for a little while and you've seen technology evolve over time. You also have seen the market change and consumer adoption change as well. And hospital at home initiatives, the pandemic, a lot of these are influencers in driving care to home. Is the home ready to be able to bring this technology into it, especially from a telemedicine perspective? Is it becoming cost effective enough to bring in stethoscopes and other things into the home instead of just a remote point of care?
That's a great question. It really depends on the type of access or internet access that a person has in a home. You still find throughout our country that in some rural areas, a lot of rural areas, that there's still the POTS line is still in place. Older folks that don't have a internet connection because there's no cable coming out to their house or there's no satellite available. That should change hopefully very soon now, and it's changed in the northern hemisphere of the United States with that little company called Starlink, Elon Musk's out of SpaceX, literally, thousands upon thousands of satellites in low orbit. That's going to change healthcare around the world, not just in the United States. But that is still an issue. As we talk about RPM, where you want to bring in chronic care and remote patient monitoring, remote therapeutic management into the home, we find that that when you don't have internet, it gets kind of difficult, and then you get relegated to either trying to do a hub that talks over the POTS line, the dial-up AOL type thing from years past, or the other side of that equation is with IVR, where standard analog devices are used by the patient in the home, and they will use a series of calling into a phone number and the automated attendant. I know I just said automated attendant, and that gives us all a scary willies. But the fact is that the IVRs have become very much intuitive to the voice, and so being able to get and glean numbers and dialogue from a patient in the home is getting better and better. And so we see that being a big increase to access to care for the people in rural settings. But it's also, I'll just say this last thing, is also in the urban settings, because there are folks, the disparity of dollars for folks that don't have internet access at home, or if they do, they may have a cell phone, and so they have to move to the cell phone for that connectivity, which with 5G and for GLTE, it's easier, it's better.
Yeah, I was hoping that actually the smart TV was one of the things that have helped bring internet into especially older individuals' homes, because of just running applications or running cable with it as well. It seems to have helped it, right, from that standpoint, but I definitely believe Starlink is going to be one of the saving graces in connecting the rural areas right together.
We have two solutions. We have classically been doing work via Wi-Fi or Bluetooth or cellular.
Mm-hmm.
And we have two solutions now that is using the smart TV as the hub. And the
Right.
peripherals in the home talk to the TV. The TV is talking to the rest of the world, typically via a cable system. And we find that whereas, and again, we're dealing primarily with an older population, and the degree of smartphones within the older population continues to go up and up. But like my parents in their 80s have smartphones, and they use 2% of their smartphone capability at best. But every 80-year-old veteran guy who's watching Andy of Mayberry on MeTV knows how to operate his smart TV. And so to the extent that he can use a blood pressure cuff that talks to his smart TV, displays the data, and then sends it where it needs to go, we think that that's the user interface of the future, and we're leaning heavily on it.
Yeah, that's exactly right. But my dad had to manipulate 4 remote controls to be able to do his smart TV, right? For whatever reason. But he was not on the grid. Mom was on the grid. Mom had 3 computers and 2 tablets, right? So I assume, Rob, that you're trying to provide a variety of different solutions. We always say one solution doesn't fit all, right? And try to align the right technology, get the right outcome at the right cost with the right person. Is that right?
Right. And we're doing that on a per patient basis, but also on a per client basis. In fact, it's funny, 15 minutes before I got on this call, one of our nurses came up and was dealing with a Texarkana, Texas client that we had shipped a cellular blood pressure cuff to, and they can't get cellular connections. And so we're kind of working through that. But delivering healthcare to that last mile in the home really requires some connectivity, whether it's cable or cellular, or worst comes to worst, POTS. It requires funding to provide it, which is why typically in remote patient monitoring, which is small dollars in the grand scheme of things, it can afford a blood pressure cuff, but it can't afford a patient-owned stethoscope or otoscope just because of the costs. And then the third is it requires the ability to present the information. So we can generally train an 80-year-old to put a blood pressure cuff on and get that data, even though 50% of our blood pressure readings are faulty due to inappropriate application of the blood pressure cuff. But then if you start to ask a patient, to do their own ears or throat or something else, it's hard to do without sending a trained presenter to the home, which again is in-home care. But once you have to deliver a healthcare person out there, it's not quite telehealth, or at least it's a different version. So it's marvelously complicated. but everyone across the board, the softwares, the hardwares, and the delivery mechanisms are all making progress. So we're very optimistic about it.
And Rob, on that, and also what you said, Dr. Weiss, about increasing access to care. I think that's, the primary mission to increase the access to care, and then also the overall patient satisfaction, the medication adherence, the occupational side of their home, that if the person does have diabetes or hypertension, that, you get to understand the living habits of the individual to actually provide them better care. And that does sometimes require sending out someone to the home, because if you're going to decrease the hospital readmissions and the average length of stay and the emergent or urgent care hospital visits, and also decrease the spend annually, I think it takes a hands-on approach with technology to solve the decreases needed and the increases needed.
We're seeing a number of motivators not at the patient level, but at the institutional level, that we're servicing hospitals and FQHCs and physician groups and such. There's the let's save money motivation, which isn't typically the number one motivation. There's the better patient care motivation. There's the keeping up with the Joneses motivation. If everyone else is doing telehealth, I want my hospital in my county doing it. But increasingly, we're seeing a fourth, and for us, a new driver, and that is health equity. And then getting out into the home, into the rural areas or the poorer urban areas, and delivering healthcare into those homes, not just the affluent suburbs, is increasingly a driver where people are saying, yeah, I want remote patient monitoring to satisfy our desires for health equity, which again is a new driver that we're seeing recently.
Rob, I think, sorry, Ken, I was just going to comment. I think that's absolutely right. In our world, we kind of bucket those discussion points under the phrase social determinants of health. Things like your geographic isolation, your economic instability, your educational and social and community disparities, areas that don't have access to clean water and nutritious foods, and so on. And I think that's a really exciting group of areas where technology can really make a difference in patients' lives. It's really easy to become wowed with new technology, and I'm one of them. I'm a technology nerd, but as an end user, not a developer, but at the end of the day, the most important thing must be: are we improving objectively care that's being delivered? And so you still got to excel in your clinical delivery metrics. Are you making the patient's diabetes better? Are you extending their lives? Are you decreasing their morbidity and mortality? Those still have to be the ultimate endpoints that we're trying to achieve.
Yeah.
Dr. Weiss, are you actually, any of your staff actually going into the home? Or is it, or at this time, or do you have plans to go into the home to do baselines or periodic, evaluations inside the home itself?
The answer, Kent, is yes and no. That is absolutely happening today with our patients, but it's really being done by VA employees, simply because that's not part of our contracts with the VA. But
right.
That's definitely happening.
Yeah, I'm seeing more and more opportunity with companies that are approaching us that go into the home for one thing. They may go into the home, I'll take an example, LabCorp. They may go into the home, or Quest Diagnostics, to do a blood draw here in Arizona. But while they're in the home, can they do other things like a retinal exam or a safety exam or a risk analysis or a med compliance exam at the same time? And all of that is very, very fundamental to the care of the patient, right? To see if they're in compliant or not. So I was just
Yeah.
curious about the
It's
home
almost
visit.
it's almost the next evolution of mobile care, where you can pilot a sonography machine or a teleretinal camera, those kinds of things, and make those technologies mobile and bring them to the patient. As Rob said, is that exactly telemedicine? No, not exactly, but
Right. But if you think of the virtual, are you guys there? If you think of the virtual care programs that are being put together by these large telehealth companies, they need to have a reach inside the home, right? Because you're not seeing people face to face. They still need the ability to get blood draws and to be able to do risk assessments and other things as well. So that becomes a very important component, right, to care as it moves forward. You're seeing companies like MedArrive and Dispatch Health and even AMR Ambulance that are out there that are doing physical visits with navigators, right, to try to baseline and then connecting them to a remote call center instead of, and trying to get early indications, right, of whether somebody's, having an issue or not. I call it a lot of times just-in-time care. Instead of just showing up and picking up somebody and taking them to the ED or the emergency room, you actually start getting data from their home on a regular basis, so you can see indications if they're decomping or not, and try to get care just in time before they need to be picked up and taken to the emergency room, right, from that. So I see that as an evolution of kind of where we're going.
Yeah, and I think that's why guys like Google and Apple are very much interested in the data flow from various forms of, we won't call it remote patient monitoring, but the more you can know about the health associated with patients, I think that is ultimately the way to go. You want to be able to keep an eye on people and then keep them out of the ER. I wanted to jump in with sort of a non sequitur because the title of this webinar today is about veteran healthcare. We did a study for AARP a few years ago where AARP challenged me and they said, hey, Ray, look, is veteran health any different than normal health? Should we really pay attention to it differently? So we did some digging, and in 60 seconds, here's what we found. Veterans, which are predominantly older now, remember that over half our 22 million veterans are over the age of 55 or 60. Veterans are more likely to be active, more likely to have insurance, more likely to get cancer screening, more likely to have regular dental care and flu shots. They're less likely to have an unmet medical need, I think because of the VA backstop, and they're less likely, slightly less, to be depressed. So they're all good things. On the other hand, veterans are more likely to drink too much. They're less likely to get enough sleep. They smoke more than the average folks. They have more cancer than the average American. They're 62% more likely to have heart disease, 67% more likely to have a heart attack, more likely to have diabetes, COPD, and more likely to be functionally impaired. So it's a good thing, bad thing. There's pros and cons, but there's good statistical data that veterans do have a different health profile than Americans at large. And again, this is based on a statistical sample of 10 million people. So it's clearly valid. And that's why we have the VA, and we have very cool things like Dr. Wise's C-Box out there across the country, taking care of this increasingly geriatric veteran population.
Right.
So sorry for throwing numbers at you, but I know you like numbers, as do I.
Yeah. Were there any causes as far as because of the increased heart attack, because of the increased diabetes? Was it because of lack of health and wellness or obesity or
no,
other
because
things?
they're more likely to have access to healthcare, and they're more likely to be active. But on the other hand, they're more likely to smoke. So,
right. Yep.
And smoking is probably habits that they picked up during their veteran time or during times of stress when deployed overseas. So it's an interesting population, and it is different, and they do have different needs. They are more predominantly rural too than the average American, which gets back to your original concept about delivering healthcare to a rural veteran. Over.
Rob, I was going to ask you really quickly, because this is actually your field. We're seeing more and more of the concept of hospital at home, right? Where they want to move. I just really make it really super simple. They need to start moving the hospital room to home, right? And what's in a hospital room? A call button, vital signs, food, med compliance, maybe care, definitely care that goes with that as well. So all that needs to be replicated across the way. Where do you see PERS playing a role with RPM and enabling that hospital at home concept?
First of all, PERS, medical alerts, personal emergency response systems, 3.3 million Americans have them. About 8% of all seniors have them. And the more senior, the older you are, the more self-evident it is that this is the very first thing to have. And then we're seeing an overlap between people that are getting remote patient monitoring and people that are getting PERS. And so PERS companies are starting to buy remote patient monitoring companies and vice versa. And then further, certain medical alert devices are now able to be the hub for remote patient monitoring peripherals. Mm-hmm. So it's all kind of swirling together in this technology capability that will probably eventually become not distinct between the two. In other words, personal emergency response and RPM will probably all be the same thing using the same technology. I see that happening soon. Now, a hospital in the home, the primary thing that is holding that up is not so much technology, but the ability to deliver acute response. We can get an alert when Mrs. Smith starts to, have difficulties at 2 o'clock on a Saturday morning. In a hospital, the help is 40 feet away. When she's at home, the help might be 40 minutes away. So it's not the tech, it's the acute response part of hospital in the home that has not yet been worked out. And I think there's going to be some quasi level of inpatient care in the hospital with 30-second response, and then at-home care that might have 45-minute response. And it won't really be hospital in the home, but it'll be better than keeping people, say, in rehab for extended periods of time. Think of it perhaps as rehab in the home. It's heading in that direction. We still haven't solved the space-time continuum, though. Being able to teleport a nurse into the bedroom of a very acute patient within 30 seconds, that's still a ways off. Elon Musk is probably working on it as we speak.
Yeah, there you go. I mean, there are assets out there that are sitting 5 minutes away from us at all times, right? And that's the fire department, right? And they're not fire departments anymore. They're actually medical departments, right? And social determinants of health, because they very rarely put out fires. So I see opportunity around
part of
that.
the solution. It might be that kind of a partnership.
Yeah. And in fact, in Arizona, we did have a grant here that actually, when a 911 call came in, they sent out a fast response team to the home. They triaged it first, right? Then they sent out a fast response team to the home, and it was incredibly successful, right? They didn't have to send out the rig. They didn't have to send out the ambulance. They actually could stabilize them at home. One other comment real quickly, then Joel, I'm going to you, is I really think, I'm sorry to synthesize this down to its core, but I always talk about data and getting data from the home, right? Is actionable data as much as you can. Pressing a PERS button is a data point, right? But the more data you can get, the more you can personalize services around a vet, around a senior, around a consumer, right? That's out there as well, and be able to just get them just-in-time care, but that's personalized to them, right, as well. So I think connected data plays an incredible big role. Joel, from your perspective on this, we touched on it before in talking about it, but one of the questions came in was about seniors' use of technology, right? And, maybe your business is more about point-to-point, doctor-to-doctor, right, from that. But, do you have senior patients or consumers or vets using your equipment today, and how are they managing with the technology?
Yeah, thank you for the question. So for us, you'll find our technology, the majority of our technology, eliminating that disparity of care inside some sort of facility.
Right.
But then you'll also find, our mobile app with patients as well, but not connecting at this time to devices, right? We reach out to companies like yours to do such things. But it really comes back to, I think, the four of us. There's 4 companies being represented here, including yours, Kent. And, the greater the access to care for all patients improves the health and well-being of the population we're trying to serve. And so, I know that the four of us work very hard to eliminate the barriers to care through the different programs that we have. And so I see a not too distant future with the continuum all being literally interlaced through the EHR and through the imaging systems, because imaging from patients is important unless it's right at that point in time, to your point, Rob, on, when there's an episode that takes place inside a home, it takes a bit of time to get there. But that continuous monitoring of the patient as wearables come more like the norm. If you're sitting at home watching TV and all of a sudden your blood pressure starts to go up through the roof, and your heart rate and your oxygen, oxygen come down and heart rate goes up, then you are probably in a situation where someone needs to know that, and that someone needs to have someone on their way to make sure you're okay. And I think we're not that far off from that. The continuous monitoring, there's some tremendous companies out right now that for wearables that I think will be a big change. And then the other side of that is this whole visual vitals piece, right? That I can be laying in bed in a sick bed and at home after a post-op or whatever the situation is, and I can have a camera literally focused on me with nothing touching me for vitals, and the camera and the software are getting the vitals from the patient. That's some of the new exciting stuff. Or you take your cell phone and look at your cell phone, and while you're speaking with your healthcare provider, the phone itself with the camera technology is reading your blood pressure, your oxygen, your pulse, your rhythm, your airflow. So it really is, those are the new things that I think are, that when we think about the home and we think about elderly people using technology, that's exciting.
Yeah.
That's exciting stuff.
Joel, I always show this hump, that's out there, and one side of it on the right is complex care.
Yeah.
A lot of money being spent over there, but very few individuals. There's this group that's in the middle of it that are newly diabetic or newly chronic, and it's stacking up over there. A lot of the RPM companies will be more in the reactive mode, right? You're already spending a lot of dollars, and that's where it's cost effective to do it. I call that RPM 2.0. RPM 3.0 is the wearable side of the equation, less technology, more disposable, but you're starting to be a little bit more proactive. And then RPM 4.0 is spatial acquisition, like you talked about. No deployment of technology other than the tablet or phone that they have, and be able to get some initial vital signs from it. And you can start there, especially the telehealth companies, to at least get some data from, I always say, from inside the theater, right? From, from the zone at home, right? From them to get that data. And if you need to deploy more assets, then you deploy more assets down the road. But you start with that facial acquisition first, right?
That 80% of the costs being with less than 20% of the populace.
Yeah.
And 20% of the populace, and then the 80% is only 20% of the cost.
It all becomes exception-based processing, right? If you can actually get people compliant and then nudge them into compliance, in the first quadrant or so, then you just deal with the delta, right? That's there as well, and you can deal with a much broader population as well. So, Dr. Wise, go ahead.
If you don't mind, I just wanted to comment on a couple of things, because I think you guys were going right where my brain was headed, but then my clinician kind of brain went off in a different direction, and it's really around leveraging the technology, the continuous data flow that I think Joel talked about, Kent, you talked about. How can we get to a point where we're more proactive versus reactive? And for me, although you haven't quite asked this question yet, for me, one of the technologies that I am most excited about right now is AI and machine learning. Artificial intelligence and machine learning are going to allow healthcare providers, a never before seen depth and speed of analysis of clinical quality data. And I think when we talk about how can we be more proactive with patients in their home if you don't have a physical body there? Well, part of the answer to that is prevention. And when you have this continuous flow of data, and then you apply or you layer AI and machine learning onto that, you start to get to the point where you're going to be able to answer a couple of really important questions faster and likely in exponentially greater depth. Questions like, well, what anomalies?
He's frozen. All right. We'll go back to him in a second. Rob, I want to ask you a question. Are you there?
Yeah, I'm here. Just to follow up on that, RPM, remote patient monitoring, has been shown that if you measure
About this patient's care.
Oops.
Sorry, Dr. Weiss, you froze there for a second, right? So we lost you the last 20 seconds or so.
Well, the second most important question is, what can we predict about the patient's care? What might happen in the next 24 hours, for example? And so when you get that continuous data flow that Joel spoke about, and you apply AI and machine learning principles on top of that, you're really going to get to a point where we're going to be able to head off or prevent urgent or more acute situations with patients in their homes. That's a pretty exciting thing.
That's exactly where I keep on talking about just-in-time care. It's about getting data in so you have predictive analytics and have people like AMR and other people that are sitting there going, we don't need to send an ambulance to pick them up and take them to the emergency room. We can actually send, somebody out that's decomping. Maybe they need to have a LASIK shot, right? To take water off them. You can do that at home instead, right? Instead of transporting them to the hospital and have that admittance into the hospital itself for 3 or 4 days. Right.
And not only that, and then we can move on at your discretion. But let's say somebody did need a bit of LASIK for a congestive heart failure exacerbation. Well, post-op patients have a pain pump that they can control to some degree on their own. Well, you can put anything in a pump like that, to include furosemide or LASIK, and they could self-deliver on advice of a clinician via telemedicine to take X milligrams of LASIK. So it's, again, really exciting things I think are available.
Dr. Weiss, Rob, just a second. Dr. Weiss, let's stay with this for a second. How are physicians doing right now? I mean, we've heard a lot of things about burnout, especially during the pandemic and stuff. And now we're laying on top of that, transitioning care to home and hospital at home and really kind of disrupting some worlds, right? What is the motivator for a physician? I mean, obviously they care about their patients, but to keep them motivated and active in the care of their patients now with this changing world?
I think that's a really important and really complex question, Ken.
Yeah.
The short answer is, I think physicians and clinicians in general are doing really poorly, as you might expect from a morale perspective. Look, in many ways, we as a healthcare community, a nation, a world, dealing with stressors of a type and magnitude that most of us haven't experienced in our lifetimes: global pandemic and its devastation, political discord, the likes of which we've not seen, war in Europe, and so on. These are all forms of psychological stress. And when you put that on top of the stress and responsibility that clinicians have of taking care of patients, it can really be a pretty bad environment. I think the key, at least from Valor's perspective, is to create a company, create an employment environment where our physicians and nurses and other clinicians have a sense of purpose other than just healthcare delivery. We're pretty fortunate at Valor Healthcare to be able to take care of some of the most deserving patients in the entire world. And that, along with some of our charitable endeavors, really gives our clinicians a sense of purpose. And it's not exclusive to healthcare. Everybody in the workforce wants a sense of purpose. But I think from our perspective, that's really what does it in terms of keeping physicians engaged, trying to decrease their stress levels, burnout, and so on.
It's interesting. Really quickly, I'll stay with you. Then Rob, I'm going back to you. I guarantee. When I was meeting with my physician in the last couple of weeks or so, it's just for a general exam. One of the things he's decided to do is take no more insurance. He's going to go to concierge service. He's going to go on and off the grid when he wants to do that. And most of the things he asked was, what can I do differently? And I said, do telehealth visits, right? Obviously to do that, because I didn't need to come in for this exam. And by the way, a phlebotomist could have come by my house a week earlier and gotten my blood draw, because a lot of us work from home still, right? Because of the pandemic. And they can come to my office, right, to do it as well. So a lot of physicians are now deciding to go through and change the way they see patients. And telehealth was kind of not adopted well before the pandemic, like 10% or 12%. The pandemic took to 75% overnight. RPM seems to be about the same level with physicians right now. They see it as, oh my God, it's going to give me more workload. It's going to be, what if I miss readings that come in? Am I going to be held liable for those readings that are coming in and stuff? But now I'm starting to see people that are actually going through and saying, I can actually manage people better, and I can actually see more patients, but more quality time with it by having this data. Do you think that physicians will go the same route with RPM that they kind of did with telehealth, or is it going to take them a while to get there?
Oh, I think it'll be very much the same evolution. I tell almost anybody who works for me, I might be the most OCD person you ever meet, and that's not unusual because physicians have to be data oriented, and to some degree we're all OCD. And so I think when just like telemedicine during the pandemic, I think the initial reaction is one that's pretty typical with change management, right? There's resistance, and then there's acceptance, and then there's teaching and learning. I think that's going to be the exact same with remote patient monitoring. We, as physicians, we love data for the most part, and the more data that we are able to leverage in taking care of a patient and making the right clinical decision, I think it'll be adopted very, very easily. We need companies like the ones that we4 are running, because we've got to lower the bar or the barrier to entry for physicians who are not comfortable with technology, and make it easier for them to adopt. I think that's the key.
Awesome. Rob, so you had a comment to make. I wanted to go back to you and give you time, right, to chime in.
It was just a brief comment about what Dr. Wise was talking about and your comment about just in time. And the state of Michigan just led a contract, and they're going to spend $5 million a year to look at the big data of all Medicaid recipients in the state of Michigan, which is a big population. And they're going to figure out who is most likely to have chronic kidney disease. And then they're going to intervene with these people before they have problems. This is in a partnership with the American Kidney Foundation, and they think that it's going to shave $100 million a year off of their costs, just by using the data and by intervening early in a preventative way. And so it's just an example of what Dr. Wise was talking about and what you were talking about, and that is getting out ahead of problems. In the same way that RPM, 100 million Americans have hypertension, and it's been proven that if you just measure it regularly and report it to a third party, heck, via IVR, via phone call, via any way, if you get a third party involved, it doubles the rate of control, which halves the rate of heart attacks and strokes and ER visits. And so it's like, wow, this is so simple, let's do it, which is why the government is now throwing money at RPM, just because it's cost effective. So we're making headway in fits and starts.
Yeah, I've actually seen a lot of initiatives going towards risk-adjusted scores or risk-adjusted factors, that you may be already treating, your value-based organization, but you may already be treating somebody for chronic kidney disease, but you're not being paid for them being a chronic kidney disease patient because you didn't test them, right? You didn't get them to nephrologists, you didn't get them diagnosed correctly. So, you could be spinning through records and saying, are they on metformin? Are they diabetic? Do they have a creatinine level at this level? And if they do, get them off the nephrologist to make sure they're diagnosed correctly and get ahead of the disease instead of waiting for it to boil its head, right? Rear its ugly head. Let's stay with you for a minute because we're going to wrap up here now. So Rob, what do you see on the roadmap for solutions, technology coming up in the next year or two, the evolution of healthcare, kind of where it's headed? And you can apply that to veterans in the VA as well, with this new program they're rolling out.
First of all, I'm not the cutting edge technology guy. We are the implementers of simple, proven technologies that range from the medical alert, which is now 50 years old and hasn't effectively changed in 50 years, to the newest blood pressure cuffs and spirometers and glucometers. We're sort of the delivery folks. And the major trend that I see is that healthcare is moving from the monolithic hospitals into the specialty clinics, into the minute clinics, past the CVSs, all the way into the home. And I see that trend continuing. And I think that's a duh statement. We all agree with that. Mm-hmm. And what I really see that's important that has happened just in the past several years is that CMS rules and reimbursements, which drives the evolution of healthcare, they're doubling down. Like every year, they're generating more codes for telehealth, for in-home care, and they're putting their money where their mouth is. And as long as that continues to happen, the government paying for preventive maintenance rather than only corrective maintenance, I think that we're going to continue to see the evolution both in software and in hardwares and in processes and in methods. So I think there's a couple of tsunamis both going in the same direction, which I think is good for patients and then good for the healthcare system as a whole.
Awesome. Joel, what about yourself? Where do you see the market going over the next, I'm not saying 3 to 5 years, I'm saying the next year or two.
Yeah. So 100 years ago, we had doctors that would either come to your home or you would go see them, but you didn't have the specialist. Today we have the specialists, right? And your primary care physician, you go to your primary, and I know we've all had this happen. You go to your primary care and you say, hey, I've got something's wrong with my ear. I don't know. And so, the doc takes their analog Welsh Allen and looks in your ear and goes, yep, there's something there. I can prescribe you azithromycin. Or here, let me do a referral over to an ENT. And so then you try to set up an appointment with the ENT. And by that time, it's either exacerbated into a real problem or it went away with the antibiotic. And so my hope and belief that when you go see your healthcare provider, whether you do so virtually or you go to their office or you see them in urgent care, the fact is that if you have that specialty situation, that those devices are connected, and at that point in time, the healthcare provider you're with gets the information, both image and data, which are both data, and then that is either jettisoned off to the specialist to make a basic diagnosis or say at that point in time, you know what, I do need to see this patient. Let's get them on right now. And so I think that time between care for the care you actually need has to compress. And I see the technologies compressing that. And I think it's going to compress it through, I think, Rob and Scott, you both mentioned, the AI and ML. So a lot of that will come from the AI making the decisions with a provider stepping on top of it to make sure that it actually made the right decision. You get that last minute. Same thing with drones. We're going to fly drones in our Air Force, but we're also going to have pilots, right? And there's no soon future where we're going to do away with pilots. If you want that human interaction and that last minute decision by the human that's got the experience as well. So,
right.
I don't know if that answers your question.
It does. But we also spend 70% more on an aircraft because we have a human inside the aircraft because of protecting the human, right? So, you do get a benefit from having drone technology, and there's probably some benefit in ML AI technology around patients too, but you're never going to replace the doctor, right? From that as well. The tool should be there as a tool for the physician, right?
So
To use it.
Star Trek, the tri-recorder, right?
Yeah.
The tricorder. And so with some of the things that we're talking about with visual vitals, we're almost to the point of our smartphone being our own tricorder.
Yeah.
Isn't that what it was called?
Yeah, tricorder, right? It is.
We've
Right.
now referenced two 1960s TV shows.
There you go. All right, but they were ahead of their time. So, Dr. Wise, we're going to wrap up here as well. But your thoughts for the next year or two of where Valor's going, or the industry in general is going?
Yeah, certainly. I think it's really about making sure that healthcare providers are leveraging data to the best of their ability. That is what creates national standards of care, practice guidelines, and so on. And as we've talked about already, the faster and the more in depth that we can process the data to point clinicians in the right direction, the better the healthcare delivery will be. And the final thing that I would just say is obviously echo the fact that all of you were just saying. It can't just be about the data and what the machine says to do. You've got to have the human factor and the trained clinician to ultimately pull the trigger one way or another in terms of how he or she thinks the patient is best served.
That's awesome. Well, we're going to go ahead and wrap up. And, I feel much better with the four of us working together. I think that we're going to bring, tremendous care to the veterans in the U.S. that we have, and to, our consumers and patients, right, as well, with this new and evolving technology. So thank you again for, attending this afternoon. I want to thank Dr. Wise and Rob and Joel for your participation and great insights. We'll be posting this recording on www.newnormal.buzz. Our next episode is Engaging the Patient in Their Care at Home. It's going to be next week on April 27th with a discussion on patient engagement strategy hosted by Henry O'Connell, CEO of Canary Speech, and Steve Trimiteri of Jumpstart Healthcare Investors, along with Sandra Elliott of Meridian Health Systems and Jeff Adams of Nuance. We hope you'll enjoy. We hope you will join us, and you can find the registration details on newnormal.buzz. And have a great evening. And thanks everybody for coming.